Our next speaker will be Dr. Abraham Kocheril from Provena Covenant Medical Center, the University of Illinois College of Medicine at Urbana-Champaign, and he will speak to us this morning on the role of genetic testing for electrical and structural cardiomyopathies. Are we there yet?
Thank you. I want to thank Dr. Leccaretti and his team for inviting me to take part in this excellent symposium. So the reason I know something about this, aside from being a practicing electrophysiologist, is that I do run an athletes clinic in Champaign in conjunction with intercollegiate athletics with the University of Illinois, where we do screening to prevent sudden cardiac death in athletes. So some of these issues come up there, and some of these issues come up in our regular patient population as well. So this is a fairly broad topic, and I had to think about how to cover this within 20 minutes. And so rather than covering every single electrical and structural cardiomyopathy, I decided to focus on hypertrophic cardiomyopathy preferentially, which will bring in some of these issues. And at the end, depending on how much time we have, I'll cover a little bit about other channelopathies. So this is a slide showing what hypertrophic cardiomyopathy looks like. So it's a heritable disease that presents clinically as unexplained thickening of the heart, most commonly affecting the left ventricle. And the main hallmark of this condition histologically is myocardial disarray. So in the left, you'll see the histologic section and a graphic showing what normal myocardial structure looks like, and in the right is the disarray. So symptoms related to hypertrophic cardiomyopathy could include palpitations, syncope, chest pain, fatigue, breathlessness, intolerance to exercise, and the feared one, of course, is sudden cardiac death. The prevalence is 1 in 500, so it's not an uncommon condition, and that was the other reason for starting with this. It turns out that the genetic data is actually strongest for long QT syndrome, so we'll touch on that a little bit later. And hypertrophic cardiomyopathy is the major cause of sudden death in people under the age of 30. So you probably all know who this is, or maybe some of you are too young to know who this is. But this is Hank Gathers. So there are a lot of athletes who have died suddenly who made hypertrophic cardiomyopathy famous. So Hank Gathers played basketball at Loyola Marymount University, and he died during a basketball game. So this is a heterogeneous disease. The presenting symptoms could be anything from asymptomatic to severe limitation. The age of onset can be infancy to middle age. And it turns out that over 20 hypertrophic cardiomyopathy susceptibility genes have been identified. The penetrance is 30 to 80% based on the mutation. We'll get into some of the contours in a minute. And the prognosis can be anything from premature sudden death to a normal quality and duration of life. And this we learn over time. Early on, when we learned about hypertrophic cardiomyopathy, we kind of had much more fear about this condition, but now we know that there are some people who live with this to a ripe old age. So this is a progressive disease associated with varying degrees of LVH with no apparent cause, and down at the bottom is a graphic showing the difference between a normal thickness of the ventricle versus hypertrophic cardiomyopathy, where more of the thickening tends to end up in the septum, but we'll look at different varieties. So whether there's obstruction or not depends on more than just the hypertrophy. So the septum tends to be hypertrophied. On the left is where the mitral valve is in a normal position, and here there's no real obstruction. If there is systolic anterior motion of the mitral valve, then there will be outflow obstruction to left ventricular outflow, and this can cause other symptoms. So this is the cardiac sarcomere. So this is where many of the mutations have been identified. I don't know how well this shows, but down at the bottom here is the beta-myosin heavy chain gene. So this is fairly prominent in patients who have hypertrophic cardiomyopathy. They can also have problems with myosin binding protein C up at the top, as well as a variety of troponin and tropomyosin mutations. The clinical diagnosis is often made with an echocardiogram. So This picture is a parasternal long axis view. The ventricular septum is labeled and it will be very thickened. So the echocardiogram can help with the location and extent of hypertrophy. It can help with estimating systolic and diastolic function, the presence and degree of systolic anterior motion of the mitral valve, which will determine the degree of obstruction, the direction and degree of mitral regurgitation, and down at the bottom, left atrial size, because atrial fibrillation is another condition that comes into the picture with hypertrophic cardiomyopathy. There is a relationship between the thickness of the left ventricular wall and the risk of sudden cardiac death. So this is a graph showing thicknesses from less than 15 millimeters to greater than 30, and you can see that there is a steady increase in the risk of sudden cardiac death as the left ventricular wall gets thicker. And that final bar, the greater than 30, has been used as an indication to implant an ICD because of the very high risk in that particular group of patients. So these are some of the mutations, and on the right are the estimated percentage of hypertrophic cardiomyopathy patients that will test positive for these. So once again, the beta-myosin heavy chain gene is prominent. 20 to 30% of hypertrophic cardiomyopathy patients will test positive for it. The other big one is the myosin binding protein C that also represents 20 to 30%. Troponin T is 3 to 5%, and then from there on, the percentages drop off. So those are the three big ones. Those are the three big mutations that'll end up coming back if you do genetic testing in these patients. So if you compare these, the beta-myosin heavy chain gene, or MYH7, again, 20 to 30% of hypertrophic cardiomyopathy. The pathogenicity is variable and may be mutation specific. Patients tend to present early with severe hypertrophy, so these are where the echocardiogram is often sufficient to make this diagnosis early on. The myosin binding protein C, or MYPBC3, is another 20 to 30%. It's associated with onset at an older age, so the hypertrophy will be identified a little bit later on. Young patients with a more severe phenotype can have mutations in this gene as well. Prognosis is similar to MYH7. And the troponin T, TNNT2, this is a situation where the hypertrophy can be mild or non-existent, and yet these patients do have a high risk of sudden death, so genetic testing is important for this particular category. So this is the risk attributable to having a mutation. So the red bar is mutation positive, the blue bar is mutation negative, and this graph shows year 1, year 2, year 3, and you can see that the outcome is worse for patients who are mutation positive. The risk of adverse cardiac outcomes goes up steadily with time. So this shows the prognostic implications of doing a genetic test and having it show a mutation. So we'll skip this. So here are some of the contours that are seen. So on the left is the sigmoid contour. 47% of patients with hypertrophic cardiomyopathy tend to have this. Only 8% will be mutation positive. The reverse curve, so this will be reminiscent of the initial description of asymmetric septal hypertrophy. Here, 35% of patients will have this, and yet 79% will be mutation positive. So there's a high yield if this particular morphology is seen. And then the other two, the apical and neutral, represent much lower percentages of these patients. So what is the role of genetic testing in hypertrophic cardiomyopathy? So the first is disease diagnosis and confirmation. So if you know that, or you're pretty sure that somebody has hypertrophic cardiomyopathy, the genetic test can help confirm it. And once you've confirmed it, then you go to the second line, which is identify asymptomatic, pre-symptomatic mutation carriers. So these are the family members. You want to make sure that family members are screened once a proband is identified. The information could help in appropriate clinical management. It can enable genetic counseling. And as I've shown, because mutation positive patients tend to have worse adverse cardiac outcomes, it can be helpful in predicting prognosis. So this graph is age versus prevalence. So in the blue is the beta-myosin heavy chain gene. The light blue or gray is cardiac troponin T, and the red is the myosin binding protein C. So what you see is that the development of LVH occurs at different ages depending on the type of mutation. So the beta-myosin heavy chain gene, the hypertrophy occurs early and can be detected early. For the myosin binding protein C, it occurs later, and similarly with cardiac troponin T. And once again, the troponin T is a mutation where you can have very mild LVH, but they do have the myocardial disarray and the risk of sudden cardiac death. So this is the downside of using echocardiography alone. So it is helpful, but depending on the cutoff that you use, so this shows 13 millimeters as a cutoff. So if they're mutation positive, there are some dots below that line where they have a normal LV thickness on echocardiogram, and yet they do have the mutation and are at risk. And the mutation negative is in the right-hand side, and you can see that there are people who have left ventricular thicknesses above that bar. And we know, for instance, in our football players, you can have thicknesses up to about 15 or 16 millimeters in people who don't have hypertrophic cardiomyopathy. So all I want you to see on this slide is that blue bar. So this is from the Heart Failure Society's practice guideline. It says genetic testing should be considered for the one most clearly affected person in a family to facilitate family screening and management, and this is a class 1 indication, level of evidence A. So we're not at a point where we can just blanket screen and pick up the diagnosis, but if there are clinical criteria that are steering you in that direction, confirming the diagnosis not only helps with making the diagnosis for the proband, but also then facilitating screening of the family to make sure that other people at risk are identified. So when you're screening the family, whether they're mutation positive or negative also has implications. So this is also from the Heart Failure Society guideline. So clinical screening for cardiomyopathy should be considered at the following times and intervals, or at any time that symptoms or signs appear. So the implication, so the first column is where the genetic testing is negative. So these folks should be looked at every 3 years until age 30. And then after the age of 30, no further screening is required unless they develop symptoms. Whereas if they're mutation positive, these are people who need ongoing screening to make sure you pick up development of LVH and development of risk. So here the guideline says every 3 years until age 30, and then every 5 years thereafter. So in both, there's this extra caution to screen every year during puberty, because that's when things might change and you want to screen a little bit more often. This is basically saying the same thing, so I'll skip that. Once you've identified the proband, you want to do what's called cascade screening of the family, so first-degree relatives, and this is one area where genetic screening has become a little bit easier. So for the proband, it's a more comprehensive screen that you're doing with the genetic testing. Once you've identified a mutation, when you're screening family members, you're looking for that particular mutation. So it's an easier test and a much less costly test to do for screening of family members. So let's talk for a minute or two about the channelopathies. So there are a variety of syndromes that have been identified as cardiac channelopathies. These include the long QT syndrome, Brugada syndrome, catecholaminergic polymorphic VT or CPVT, the short QT syndrome, and there are a few others, but we'll talk a little bit about long QT. So this is where these mutations have their effect. It's in the ion channels. So the graph shows potassium channels, which mediate repolarization. Sodium and calcium are involved in depolarization, and then there's the sodium-calcium exchanger. This is the action potential. So we've learned a lot about this over time, and we've learned which channels are involved. So the upstroke of the action potential is dependent on sodium channels or the SCN5A gene. The maintenance is by calcium, repolarization is by potassium channels, and so we've learned a lot about potassium channels and other proteins nearby that affect the potassium channel. So this is a breakdown of the sudden arrhythmia death syndromes. So of the ones where problems have been identified, long QT is the most prominent, accounting for 28%. There can be no diagnosis in up to 46%. And so this is one of the limitations of genetic testing at this current point. So this is why QT gets prolonged. It's because repolarization is prolonged, the action potential duration is prolonged. And these are some of the genes that have been identified. So the first three are the most common. So there's LQT1, LQT2, and LQT3. So LQT1 occurs in 30 to 35%, LQT2 in 25 to 30%, and the LQT3, which is once again mediated by the sodium channel, 5 to 10%. All the rest are fairly uncommon. And when this has been used in practice, it turns out that 1, 2, and 3 account for 75% of the mutation-positive patients, and the others account for another 5%. So in 80%, you'll get a mutation that's responsible for their long QT syndrome. The other 20%, you won't. So that's another thing to be aware of, that if they're mutation negative, that doesn't necessarily mean they don't have long QT syndrome. It's just that if they're mutation positive, then you can do the family screening and the prognostication. So these are some of the differences. These are arrhythmia triggers. So long QT1, the trigger is often exercise, and especially swimming. In long QT2, trigger is emotion. So these are the patients who die suddenly with the alarm clock going off in the morning and with other types of startle. Long QT3 is where the sudden death events occur while at rest or during sleep. So this is event frequency. So we worry the most about LQT3 of these three because it's hard to counsel patients if the events are happening during sleep. However, LQT1 is the most common, and we can tell those folks to be careful with exercise. Again, swimming is the big red flag, and LQT2 is in between as far as frequency. So here again, the roles are similar. You want to use genetic testing for disease diagnosis and confirmation. It's part of a comprehensive risk assessment. You can advise on lifestyle modifications. You can aid, or your workup can aid in whether to place an ICD to protect patients or not. And then importantly, there's the family testing aspect. I'm gonna skip over a couple of slides for the sake of time. So the question was, are we there yet? And the quick answer is not quite, although we've come a long way. So here's what genetic testing can do. A positive test can confirm the diagnosis and can be used to screen family members. And if the family members test negative, then we don't have to worry as much about them. We don't have to do ongoing screening. A negative test, unfortunately, doesn't rule out a condition because there are genes yet to be discovered. The yield for these conditions is in the range of 30 to 80%. Long QT syndrome has the most data and has the highest yield. In Brugada syndrome, for instance, only 25% will come back with a positive test. In making clinical decisions, there are still gray areas. So there are clinics around the country that specialize in hypertrophic cardiomyopathy. I didn't mention the use of the magnetic resonance scan, but this has been used to aid in making this diagnosis because you can pick up patchy areas of fibrosis in this condition. And if that's positive, that's helpful. It can be more helpful than the genetic information, and both are more helpful than the echocardiogram alone. CPVT is a condition where 50% of the patients will have a mutation in the ranitidine receptor, and this can be helpful for, once again, diagnosis and prognostication. One of the good things that's come along is that genetic testing used to be much more expensive and would take a year or more to get a diagnosis back. And now the costs have come down significantly, and you can get the results back in about 6 weeks, sometimes shorter depending on what you're asking for. So there have been significant improvements, but we still have a little ways to go in using this more comprehensively and more widely. So recent article on CPVT, I'm sorry, on ARVC, arrhythmogenic right ventricular cardiomyopathy, which is now in the guidelines as arrhythmogenic cardiomyopathy because it could be the right or left ventricle. Here, this was a study looking at athletes versus non-athletes, and what they found was that the event rate was higher for athletes, so there is an interaction between having one of these genetic conditions and athletic or high-intensity physical performance that increases the risk of sudden cardiac death. Finally, this is a good review. This is from Europace in 2011. This is written by people who've done the most work on channelopathies and cardiomyopathies. I'll just mention as an aside that genes have been identified for atrial fibrillation, and I spent a lot of time treating atrial fibrillation, and unfortunately, the genetic testing hasn't really come along very far in that. In fact, these guidelines say that testing is not indicated for atrial fibrillation. So I'll stop here. Thank you again for having me. This is my first visit to Kansas City.